Welcome to Talking Women's Health podcast. I'm Amy Young. I'm the CEO of ABOG, and this is where we have the opportunity to talk to amazing leaders in women's health care. Today, the topic of today's podcast is Pediatric and Adolescent Gynecology, or PAG as we like to talk about it. PAG is currently a Focused Practice Designation of ABOG, but we're moving to Subspecialty designation. And the reasons for that, we're going to discuss with my guest here today, and I'll introduce you in a minute. But essentially, Pediatric Adolescent Gynecology, or PAG, represents a distinct science over and above that of general OBGYNs. And moreover, there's a patient population of children and adolescents that are benefited by the formation of PAG. So I'd like to take a moment and introduce my guests. I have the pleasure today of having Dr. Jennifer Dietrich and Dr. Nichole Tyson. I had the good fortune of recruiting Jennifer back to Baylor College of Medicine once upon a time with my chair, Dr. Dale Brown. So she's been since 2007 the head of pediatric gynecology at Baylor College of Medicine at Texas Children's Hospital, and she has been the fellowship director since that time. She's also served as the president of the North American Society of Pediatric and Adolescent Gynecology. And Dr. Tyson is about to assume the role of president of NASPAG, or the North American Society of Pediatric and Adolescent Gynecology. She's at Stanford University, and she heads up the PAG program there. So I'm so delighted to have both of you here today. All right, so let's just dive in. I think it would be really great for our listeners, and some people are watching the video, to understand more about what PAG is. So Jennifer, you want to just take us through that?
Sure. Thanks so much for having me. I'm really glad to be here. And so, pediatric and adolescent gynecology is a unique field within gynecology. And, really we're focused on the patient from infancy to young adulthood. And I think what really sets us apart is that we are focused on reproductive health care for our patients, but really we are personalizing the care for their developmental stage throughout the lifespan.
Dr. Tyson, do you have anything you want to add?
Yeah, I think it's a great subspecialty of PAG, or of OBGYN, which sets us apart from OBGYNs in that we see consults maybe that the OBGYNs or the pediatric specialists don't necessarily feel comfortable seeing, from sometimes even, pediatric patients to adolescents, and then even young adults who are transitioning into adult care. So it's a really nice continuum of care for our younger gynecologic patients.
When I, started my career, PAG was just sort of a niche, right? If you were a general OBGYN, you might have a niche of PAG. But when I was reading about you in preparation for this podcast today, you guys both have 20-year career solely dedicated to PAG. Can you talk a little bit to me about that evolution from just being a niche to a full-time practice? And Cole, why don't we start with you on this one?
Yeah, I have actually been an OBGYN for most of my career, having done, obstetrics and gynecology, and kind of increasing my surgical volume over time and having PAG. And it's only been the last 5 years since I came to Stanford that I've been doing solely PAG. There's some gynecology because we want to always support our team. But it's a pretty special and high volume practice now, because when you open the doors of, hey, we're here to take care of this patient population, they find us. Jen and I talk about this all the time. We get abundant referrals beyond what we can handle the capacity of. And so I think once you can make yourself found in that population, and there's so few of us, it's a really rewarding experience.
And Jen, I know because you were a resident with us, I would occasionally do a PAG case.
Yeah.
We've done some together.
Yes.
But then you've dedicated your entire career solely to PAG.
Yeah.
So one of the things we're talking about today is the need for the creation of a subspecialty.
Correct.
So can you just help our audience understand what is subspecialization going to do for us? What is it really going to do for the patients, and why is it so necessary?
Yeah. Well, I think that healthcare has evolved, and it's certainly become more complex. And with complexity becomes the opportunity for subspecialization. And so really, with subspecialization in this area specifically, it will standardize the care of people in training. And really, it will allow us to then provide a consistent PAG specialist where people can really be focused on delivering consistent care and seeing this population 100% of the time. So that consistency is really important. And the standardization is really important, because once we kind of focus on that, then we are going to have some oversight and some accountability long term. And that's not only important to our patients and families, but also our colleagues with whom we consult every day.
You know, I've been really fortunate in my career because I've had access to PAG specialists, and I've built PAG programs, you know, as a chair in different institutions, because the conditions are so complex that they really require a skill set that's kind of above and beyond that of a general OBGYN. And not only that, that complexity, you know, it's a lifetime for these patients, right? You know, in order to optimize care for the patients, I think a lot of times the complexity of the disease requires a multidisciplinary team. Nichole, who are some of the people that you work with when you take care of these patients?
Yeah, I mean, it's really quite fun for us in PAG because we cross almost all of the specialties you can think of. But routinely, things like hematology and oncology for our kids with bleeding disorders, or cancer patients, or endocrinology. Certainly our pediatric surgeons and pediatric urologists, and even sometimes our neurosurgeons and GI surgeons. We are routinely getting consults from all different specialties. Once they kind of learn about the practice that you're doing and the support that you can provide, that maybe they don't have that skills or don't have that time or resources, then they really are loving that opportunity to take care of that whole patient and their reproductive health at that time and for the future. So that part is like a really enjoyable enmeshing with all these different specialties.
So, you know, in the little bit of knowledge that I have about PAG, I know that you guys work together in, you know, comprehensive centers. So you're working kind of shoulder to shoulder in the outpatient setting, but you're also operating shoulder to shoulder to maximize the outcome for these patients. So what does that look like?
I mean, it's also really collaborative, and it's really great for growing your surgical skills. I think I do a lot of surgical coaching too, so learning from other specialties can enrich your specialty. And so that's very bi-directional. We learn a lot from our pediatric surgeons. They learn a lot from us. And then we know that patients are getting their care addressed. And so maybe, you know, in something like a large pelvic mass, and they're concerned about the fallopian tube or the uterus and the cervix, and maybe that's not their, you know, fulcrum of anatomy focus all the time, but it is certainly ours. And vice versa, like what's going on here with this lymph node, or how can we optimize these adhesions and keep her bowel safe? I mean, it's like operating with a nice partner who has amazing skills, and you know you're doing the best thing for that little patient in front of you. So it's a really great collaboration. I've found it rewarding throughout my whole career.
And Jennifer, one of the things that you talked about, the need for subspecialization, is really standardization.
Right.
When I think about that, I think about it from the perspective of the consultant. So they always know what they're getting, right? So with subspecialization, we'll bring that level of standardization. One of the other things that I think is just unique about PAG that differentiates it is that you take care of these patients through the continuum, right? Many of these people have abnormalities early in childhood, or even in infancy, right? And so you end up taking care of them throughout their life cycle.
Absolutely.
What does that feel like in the world of PAG?
I mean, it's an amazing experience to be able to be involved in their healthcare from such a young age, all the way into young adulthood, see them blossom and get to the next stage of their reproductive health. And I agree with Nichole. I mean, the collaborations that we have are critical. They're paramount to what we do. And that communication, that coordination of care is so important, not only because we see it as colleagues, but it is important to our patients, our families, because it immediately instills trust in our healthcare team, the healthcare system, and that their reproductive health care is going to be managed throughout their lifespan, that we're not going to forget about it, just having seen them early on and never again. that's just not the case for us. We continue to follow them.
And trust building is a big deal right now.
Yeah.
So it matters a lot to see that.
When you have more than one patient, the way that I see it, you have the patient, the family is really, in some respects, your patient as well. You know, having built programs and recruited individuals to create PAG programs in different places, I've also seen what happens when PAG doesn't exist and you don't really have that multidisciplinary focus and that, you know, that longitudinal experience. Have either of you experienced environments where that collaboration really wasn't there? And what do you think the effects are on patients and families in that situation?
Yeah, I mean, I think that we've all seen circumstances in front of us, especially in the emergency setting. I would say I've seen that a little bit more, where perhaps, you know, one of our colleagues in a different subspecialty may need to take a child back to the operating room. And it is not uncommon that perhaps they may give one of my team members a call from the operating room because of the relationship that we have. It may not be that we can be there physically because they might be at another campus, for instance, but they know they can call us. And even if, for instance, if they didn't call, that patient may come to us later on. And I think that what I have seen them do often is say, hey, you had an ovarian torsion. We removed an ovarian cyst, but I need you to go and see an OBGYN specialist after this to talk about next steps if you might have another ovarian cyst and talk about any implications to your reproductive health. And so still, even in that circumstance, if we weren't physically involved in the procedure for that patient, we're involved on the back end nonetheless. And that's really important for families. They have more questions about the reproductive future than anything else.
So I think I'm going to paraphrase what you said to me, maybe a little bit differently. I think that this longitudinal relationship that you have gives you the opportunity to intervene in different aspects. So, for example, the explanation that you just gave, you're really providing preventive care, right?
Yep.
We've had a torsion. How do we prevent basically another torsion, right? So it's different from just doing a procedure. It's really about more of a holistic, longitudinal relationship that you may have with that patient.
Absolutely.
I would say, too, there's times where maybe the patient seems like they need surgery and it's acute, but there's actually other options where you might want to optimize timing. Maybe there is a problem with the vagina and things are obstructed, and maybe there's ways that we can help as a PAG team to support the surgeons or the colleagues who are consulting with suppressing menses, let time build, and let us teach them how to optimize their vagina timing of surgery and then the progress after. So then sometimes they're not facing repeated surgeries or complications. And I mean, I think it all has to do with how we are really good and adept at assessing maturity, other options that are more medically conservative at the time or not if it's not necessary. But it is a sort of a team building collaboration with patients and parents and then other surgeons who are going to see them. Because like Jen said, we're not everywhere. And so we're often consulting friends and colleagues from across the country, even each other. We have patients that have seen each other because they find the different institutions to get consultations. And then we can communicate and try to do the best thing for them.
So another thing that I think I've heard you say is that understanding really the normal reproductive cycle is really important in the care of this particular population with these really complex abnormalities, right?
Absolutely.
It may not require treatment today. There might be an optimal time of treatment, but really understanding that through the life cycle of the child and adolescent is another really important aspect that you guys bring.
Right. And it's really difficult because every 11-year-old is not the same as the next 11-year-old. So getting to understand where that person is at their development is really critical. And I mean, we're all very, very equipped and good at that.
So I do want to circle back to this issue of subspecialization. My understanding of the process is that there are several factors that are important as we move forward two bodies are particularly important, the ACG and me, because they control residency and fellow education. The second group is important, is really my board, which is the American Board of Medical Specialties. Both of those require that for something to become a subspecialty, that there is a distinct science, number one, and number two, that there's a distinct population of patients to be benefited. And the most important aspect of moving to subspecialization is it creates a level of standardization.
Correct.
You know, Jennifer, you talked about that before, but it's really setting expectations on a public level.
Right.
But it's also setting expectations for the multidisciplinary colleagues that you guys work with. Would that be a correct statement?
Absolutely.
I would say so too.
Yeah.
And I would say the idea of the public is actually really important too, because number one, it validates this as a subspecialty, and it helps optimize the recognition that these are a different population of patients who need a different level of care. And so in some ways it sort of validates and brings to light that this specialty exists, because when patients and families learn about PAG, that's who they want to see. I mean, we do know this from time and time again. So drawing awareness to this new specialty, if you will, which isn't new to us, is actually a big asset to getting our subspecialty approval moving forward.
You know, one of the things that I think it makes people nervous a little bit with subspecialization is that there's sort of like a divide. And we know from our other subspecialties in OBGYN that's not true, right? As a specialist, which I am, as a specialist, you may practice a little reproductive endocrinology and infertility. You may practice a little bit of PAG, right? There's sort of room for everybody,
Right.
but there is a level of complexity where where more is needed.
Yeah. Absolutely.
So I really want to thank you guys for being here today. You kind of get to have the last word. That's part of what my formula for my show. And so I'd like to give you each, a minute or two to share some parting words with our audience today. Yeah. Would you like to go first?
Absolutely. I mean, I think first of all, you brought up early in our conversation, I dedicated my entire career to this patient population. And it's interesting because in my journey to this place, I was actually inspired by a pediatric surgeon as a medical student to take this career path. And it was that pediatric surgeon who saw that I had a passion for women's health and for reproductive health as I assigned myself to all of the ovarian cyst cases in the pediatric surgery suite, working with the residents at that time. And he said, really, there is a pathway to this subspecialty through OBGYN. We really would like you to take a path of surgery, but we see what your passion is. And even further still, I have been inspired by my own father, who is a general OBGYN and has been a specialist for many years, is now kind of focusing on education, but supported me in going in this direction. And because there were more opportunities to focus on this patient population, it really became important. I saw the need, there has been a need, the need continues to grow. And so I think as we decrease variation with this subspecialty movement, it is only going to increase confidence from our patients, our families, and our colleagues with whom we collaborate every single day. And, I think it's really just for the benefit of their reproductive health, not only now, what we're seeing acutely, but in the long term.
Beautifully put.
Do you have some final words for us?
Well, I would say I truly have been mentored and sponsored in all the different ways you can be in medicine, also not necessarily by PAG people. Sometimes they are REI or they're endocrinologists, and a lot of pediatric surgeons as well, because they see our passion and skill for surgery. But I think one of the beautiful things about this subspecialty that we can give back is to our younger colleagues to say, we see you, we support you, we love this passion. So watching, our fellowships grow and all the young people coming into OBGYN who know what PAG is and know to call us when they're seeing a challenging patient or a PAG pertinent patient is really exciting. It's beautiful to watch our specialty grow and blossom over 20 years, and we want to leave it, better and stronger for our colleagues and our younger population and our kids that we take care of. I mean, this is a huge gift that we can give and sort of leave to the next generations.
You know, being the CEO of ABOG, I mean, one of our responsibilities through certification is to optimize outcomes for patients. And, you know, the board and our team firmly believes that in order to optimize outcomes for this patient population, PAG needs to be a subspecialty. So we're continuing to move in this direction. So I'd like to thank you all for joining me on this episode of Talking Women's Health. We will have some upcoming episodes, and I'd like to thank my guests for being here today.
Thank you. Thanks for having us.
Thanks.